Greetings, my name is Patrick Howard. I serve as the CEO of the Housing Authority of Travis County. And as part of our Let's Talk About It series, we are pleased to share that August is considered to be National Wellness Month. And as a result of such, I wanted to have a conversation with some subject matter experts about determinants of health. And so with me today, I have two distinguished guests. I feel a little bit out of my league in terms of talking to these gentlemen, but I'm so happy to be able to have this conversation with you all. Dr. Pat Lee, and he serves as the Central Health's president and CEO, and I think that's been that you've been there since December of 2023. He previously served in a similar role in Brooklyn, New York. I'm from New Jersey, so New York. Pleased to have you here in this community. And then we also have Dr. Tim Mercer. He also works at Central Health. It says you're the director of high-risk populations, but he has two other positions that are very interesting. He's with CommuniCare Health Center as a primary care physician, and he's also serving at the UT Medical School, Dell Medical School at UT. Don't know how you have time to do all those things, but we are happy to have you here. You both talking about the determinants of health and why they're critically important. Well, obviously, housing is a part of those determinants of health, and so I felt like tying that to the overarching other indicators of how we determine the stability and health of our community and our folks that live in our community. I thought it'd be really appropriate to talk to you all today, and thank you again for wanting to participate. So I thought maybe you could share a little bit about your background before we got started, a little more about your backgrounds, and then we'll just go ahead with the discussion.
Well, Patrick, thanks for having us. Truly an honor, and delighted to be here with my colleague, Dr. Mercer. I'm a primary care physician by training. Actually did a lot of work in different parts of global health and community health, and along the way developed a conviction that in healthcare, particularly caring for vulnerable communities, our most important business is actually trust. So the whole point of everything we do is to earn trust. And if we do that right, it changes everything. And we can then talk about whole person care, which is where social determinants comes in, but so much more than social determinants. We're talking about physical health, behavioral health, dental surgery. We're talking about nutrition, education, housing, transportation. We're talking about a sense of being seen and a sense of belonging and a sense of, hey, this team, this place is really here for me. I feel safe, right? And if we could do that for everybody who needs us, one size fits one, not just one size fits all, then I think that is actually the key to solving the problem of health equity, of healthcare disparities, the 10 to 20-year life expectancy gap that exists east and west of I-35 has deep historical roots. And so I'm just really honored to be here in the community, in this amazing small, big town in our greater Austin community. We could do some of this work with amazing people. So thanks for having us here, Patrick.
Absolutely. Thank you.
Yeah, thank you, Patrick, for inviting us here. Really is an honor. So a little bit of background about me. I'm also an internal medicine primary care physician by training, and similar to Dr. Lee, spent a lot of my career early on and still to this day working in other parts of the world and just sharing. We're talking about social determinants of health today. It's a very brief anecdote. In my first year of medical school, steeped in learning biochemistry and genetics and anatomy and physiology and all the reasons why people get sick or don't, and then had the experience to travel to rural Kenya and East Africa and lived and worked at a rural health center. And everything I learned the first year of medical school was out the window, and it had much more to do with where you live, your economics, family, culture, all of that. And so very early on was kind of steeped in the importance of the social determinants of health. And fast forward, now my clinical practice is caring, the deep privilege of caring for people experiencing homelessness and suffering other vulnerabilities, and see that day in and day out and how that comes to bear on their health, and importantly how we can work to solve that and work together with partners like yourself in housing. So look forward to the conversation. Thanks for having us.
Wonderful. It's amazing how things come full circle. That's That's really inspiring. Well, we'll get started. I'm actually going to go through the questions because my memory's not great, and we did a lot of work to get these get some good questions here. So the first being this is, what are the key social determinants of health affecting this community, and how do they vary based on neighborhoods? And you talked about east and west of 35, so maybe in that context.
Yeah, I mean, I can start with the one I know and see every day, and I know it's part of your world too, around housing. There are many social determinants of health: food and housing and transportation and communication and your work and other things. But I mean, housing is just so key and so important, and the lack of it can be so perilous for our neighbors and for our patients. We know that people experiencing homelessness, chronically living out on the street, suffer a 10 times higher mortality rate than the general population, dying on average in their early 50s. So 20, 30-year reduction in lifespan. It's hardly any disease that has that profound effect.
Wow.
And we can go through more details as the conversation goes on, but you can just kind of run the list of almost every condition that's more common or worse outcomes if you don't have a roof over your head.
Yeah.
Sort of seeing that every day. So it has a profound difference, and it's a really big issue in our community due to housing unaffordability and et cetera.
Right.
So.
Yeah. And if I build on that, we know that transportation is the number one gap to care that our patients describe. And that transportation is a bit nuanced. Folks oftentimes have a preference as to where they want to go. It may not be the closest place, but it's a place where they feel they can get what they need, where they feel they've established a tie and a point of trust. So, for example, we have two large hubs to our outpatient network. One is on Metropolis Boulevard, the Southeast Health and Wellness Center, and one is in the North Central region, north of the river. A lot of folks would go to those hub sites because they can get many different services there, and we have Zumba classes and teaching kitchens, all kinds of good stuff. And so we actually operate a pretty substantial fleet management program at Central Health, and at Community Care, and at Sendero Health. We're working to even bring some of these together, but we spend a great deal of our effort making sure people can get the rides to and from where they need to go. And then there's different versions of that. If you have mobility challenges, you're in a wheelchair, right? So solving for transportation is a big deal. We also solve by that providing care remotely through telemed or mobily, going to people or going to permanent supportive housing locations and into the jail system and so on. Food is another huge social determinant. There's a lot of folks who describe they're not getting as much food. They're making choices to forego other needs in order to be able to pay for food. They're going without full nutrition. That affects chronic diseases. That affects kids trying to go to school and trying to pay attention. So we actually this year leaned into food as medicine, a food pharmacy program that we are rolling out through a number of our sites in partnership with the Greater Austin Food Bank to make sure that we can meet those food requirements. Education is a huge need. And so we've been partnering with the Austin Community College, beginning to think about partnering with St. Edward's University, obviously partnering with Dell Medical School and University of Texas. A program I would lift up is a Earn and Learn program for medical assistants. So you can actually earn a medical assistant's salary while you get your accelerated training, and then you can actually, come work with us. And so we've had about 36 folks come through the Earn and Learn program with the ACC. The majority of whom are now employed as medical assistants in Central Health Community Care. So I share all that to say that it's comprehensive. It is largely geographic. It does follow that 100-year history of redlining that we have in our community. It follows that mortality gap. It is unfortunately the case that in Travis County, the strongest determinant of your lifespan may actually be your zip code, and that's just the uncomfortable truth, and that's true in our community. It's true in a lot of urban communities around the country.
Well, I heard some common themes there about trust. You talked about education, but one of the words that you use quite often was partnership. So it seems as if to solve the problem, I mean, really, and have a real impact, it's going to require these partnerships. And it sounds like you all have really spent a lot of time talking about and really building those partnerships, I should say. And I think that's critical. I see that in our business as well. And so, talking about housing, I mean, maybe we could just talk a little bit more about housing in terms of housing quality and what you've seen in terms of what the impact is, and you shared a little bit about it. But maybe you can expound on that notion of how great an impact is that when you talk about substandard housing versus quality housing.
Yeah, I mean, as mentioned, housing is just such a important driver of health, or the lack thereof, of poor health, and highlighting that mortality gap, that you're dying, decades earlier if you don't have housing. But then just sort of going through the list, and I've seen this now for 8 years in practice in this community. People experiencing homelessness have higher rates of chronic conditions like heart disease, or maybe they had high blood pressure, and that's simple enough to manage, but then you're on the street, and lack of housing, you don't have great access to care, it's hard to manage your medicines, hard to engage in good nutrition, physical activity, and that simple high blood pressure turns into very complex advanced heart failure, and you're in and out of the hospital. And so we see that over and over, patterns. Same examples with diabetes, things like that. We see that also with mental health conditions and substance use disorders and addiction, that being on the street is actually drivers of those conditions and making that worse. And those are often consequences of living a life on the street, rather than a cause. Then we have problems with accessing care. Pat talked about transportation, getting to where you need to go. If you're living in a camp with all your worldly belongings, and maybe your pet who is your sole companion,
Right.
or your network, and you're worried your things are going to get stolen, that changes the equation of making it to your appointments, or if you're competing every day for your survival needs. A preventive care visit with your primary care physician gets deprioritized over trying to get housing or trying to find your next meal. Then you get within the health system, and unfortunately, my patients have experienced a lot of discrimination, and being treated unfairly and stereotyped and judged within the health system. And to Pat's point around trust, I think that's one of the things we're really trying to push back against, to embrace them, bring folks in with love and compassion, and give them dignity. And sometimes we can't cure their condition that day, but we can humanize them and provide them, that dignity that they don't get day to day. And so, the list goes on, and having a roof over your head is just such a stabilizing force. It's not always a magic wand. There's still work to do, and improving someone's health, but it's just so fundamentally important to then be able to address the other things. And then I know a part of your question was also, then once you get into housing, not all housing is equal, right? And do you have housing that's available to you in a safe neighborhood, or where the electricity and the water reliably works, or that's accessible if you have a disability, or things like that. And so it's not enough just to provide any housing. We have to provide people with the housing that they need, and that matches their needs in terms of services and things like that.
Excellent.
And if I could build for a moment, I just want to lift up a few of the concepts that Dr. Mercer mentioned that I just think are so important. It gives me such joy to be on this team. I heard you say love, compassion, and dignity. I just want to say that again: love, compassion, and dignity. And I want to lift up a recent story from our medical respite program. As Dr. Mercer mentioned, just about a month ago, we launched our own medical respite program. It's at the old Brackenridge campus, where the old children's hospital used to be, on the ground floor, with a kind of beautiful healing garden attached to it, and on-site clinical services that are on the side of what used to be the transplant clinic, which means that it's beautiful and dignified. And we've only been doing this for a few weeks now, but I was talking with the teams who are leading that work just yesterday, and they shared with me what it feels like. So I said, it's one thing to at least have a place to sleep, but if you're still feeling hot all the time, if it's uncomfortable, if there's flies on you, if it's noisy, it doesn't have that sense of peace. Patients would describe that the sort of horizon line of their aspiration, their dream, is I I just don't want to be uncomfortable anymore, right? I just want, I want these flies gone. I don't want to be hot anymore. That's about as far as you can see when that is your whole, the whole experience you're feeling. They described a situation now in our environment where we have built this environment with love, compassion, dignity in mind, and every single person who's working there is there with that intention. They say it feels calm. Folks are making art together. Right? They are playing Connect Four together, and they are beginning to dream about the future. I think on the second day of being there, somebody got their food handling license on their own and told our team, "This is the first time I've done something like this for me in my life." Right? I feel like I can see further, and so housing is vital. And the way in which we are able to put an environment around the people who are in those environments that communicates love, compassion, dignity is just as vital, maybe more vital. So I just want to lift that up. It's the human element that ultimately completes that circle and helps somebody have that chance to change that trajectory of their lives in a way that really speaks to where they want to go.
That's powerful. Love, compassion, dignity, right?
Yes, sir.
I love it. So what can we do? I'm a houser. I mean, what you share, we believe similarly, right? I mean, that we could change the trajectory of someone's life by providing stable housing. We know that we need to partner with others to help address some of these other issues, but obviously our primary focus is housing. So what can agencies like mine do more of to really sort of address the issue of all the other factors, and including housing? I mean, what do you all think?
Yeah. Maybe I can go first and then invite you to build. I love the way that you keep coming back to the concept of partnership. We think that's essential. Just to lift up, I know something that we all know, but for the sake of all our audience members, as we look around the country and understand, well, what seems to work here? We know we need at least three things. We got to have the housing that's right for people and meet people where they are. Not every housing is the same for every person. We have to have the care that people need all along the way. And then we have to have the continuity. We have to have the trust. If we start and stop, if we meet you and then we drop you, we don't get to restart in the same place. And that means that no one agency is going to be able to provide everything that each individual person needs. And so we have to work together in true partnership, always with that person at the center, with love, compassion, dignity, smart systems, shared data, right? Seamless processes, trust and relationships among us, each other's cell phone numbers, so that we can create new connections that didn't exist before.
Right.
I'll lift up one of those connections and sort of, brag on our colleagues at EMS. So the Austin Travis County, emergency medical system is one of the most innovative and forward-thinking, I think, in the whole country.
Wow.
I think that's an objective statement. And they're so innovative. They were saying, a lot of the time where you get a 911 call and the person calling in doesn't need to be an emergency department. They don't need an ambulance. They need a blanket. They need a refill for their medicines. They need a MAP card. They need to get into primary care. And we're paramedics, but we're going to try and solve this problem. And they built an entire system to try and do some of that without ambulances, connected to all kinds of resources, and realized, actually, that's our core competence. That's what we do. How can we work together? And we actually worked together to create a bridge clinic that I know, Dr. Mercer and colleagues were instrumental in creating. And we now have a direct connection with EMS, where rather than go to the emergency department, go through the hospital system, in many cases, that call comes directly to us. We make sure someone's safe. They come to us. And maybe I'll invite Dr. Mercer to talk about when that happens. What's that look like? What's that feel like? And just how unusual is that? And why is it that we're able to do that at Central Health, as the public's hospital district, taxpayer funded, accountable to the public, here not to create shareholder value, but here to create as much health as we can and lower the burden on taxpayers over the long term as best we can. If we're going to pay for this downstream, much greater cost with a worse outcome, why don't we pay for it upstream? Get a lot more out of that public dollar and treat people with love, compassion, dignity. So I'll turn over to Dr. Mercer.
Yeah, just to provide some more details of the Bridge Clinic model and the partnership with EMS and others that I think will get at how we're really addressing social determinants of health. So, they get a call from someone who's typically on the street, and the phenotype of this patient over and over is someone who's just kind of completely disconnected from the care system, suffering, struggling, trying to survive day by day, but maybe hasn't seen a physician in 6 months or 2 years, or has occasionally by wandering in and out of the emergency room to get an acute need met here and there, but not actual continuous care. And the emergency department isn't the best space for them, so they bring them into our clinic, and we're able to hold on to them. Often keep them there all day, let them rest, provide them with snacks, food, and kind of cycle our team through the nurse, the physician, the social worker, the counselor, the addiction specialist, the psychiatrist, and kind of addressing all those needs. Because if we're going to believe the data around social determinants of health, that only 20% of someone's health outcomes are affected by what doctors do in clinics and hospitals, and the other 80% is the housing, the transportation, the food, all the other social determinants of health, then we can't keep, implementing the same care model of bringing someone in for a 15-minute visit and churning them out and telling them to eat better and exercise more and go to the housing authority to talk to them about that. That's not our problem. No, it is our problem, because they're our problem and their health matters to us. And so we have to kind of flip the care model around to be able to respond to that. So patient comes in, we can keep them there. Case manager, social worker can address their social needs in a real meaningful way, getting on the phone, calling a housing agency, sitting with them and filling out an application for food assistance, bringing those partners to the table. And I think that's what it's going to take to care for each person one by one and also start to change the system as a whole.
Oh, that is powerful. I've been here 10 years, and I don't think I was aware of that, the model working that way. That's I'm really intrigued by that. That is, but it speaks to all of what you all have been saying, and just about, again, really addressing the core needs as opposed to just doing what everyone else is doing and looking at it in just a very conventional way. That's powerful. I'm so glad you all share that. I'm enlightened just because I wasn't aware, and I feel like now I can go and talk about it and share a little bit more. So I'll be getting some more information about that
please,
as we continue. But so just lastly, I think I just want to talk maybe about policy reform potentially. Maybe, I know the state of the world is different and ever changing, but I mean, what if there were policy changes that could be made local, state, federal level? What would you say could potentially be done to address some, many, or all of these determinants of health? Obviously, we have a very strong interest in housing, but because it's our thrust. But what do you all think? I mean, what could be done? How could you all, us in partnership, lobby, to figure out how to address some of these needs in a better way?
Could I build on the story we we're just telling and point to that question? So I want to pick up the story and to your to sort of to take you off the hook here a little bit. This thing we described has been up and running for less than a year.
Okay.
We just got going when we realized, hey, this is missing. We need something here in the middle.
Okay.
And we had the privilege of inviting our county judge, Judge Andy Brown, a county commissioner, Commissioner Ann Howard, to come and visit and tour this site. And Commissioner Howard in particular is very well plugged in and very knowledgeable from her leadership of ECHO and so on in the past. So as she grasped what we were doing, she paused, said, "Wait, how are y'all paying for this?" Right, and I just want to lift that up. This doesn't sound like your typical model. I'll tell you now, this model is not making money for Central Health, but that is the point I want to lift up. I'm going to step back a little bit, there is something called the cost of care that's often used. Insurance companies are often thinking about the cost of care. What that really is, it's the cost of medical care. Physician visits, pharmaceuticals, procedures, diagnostics. That's a big part of it, but it's not all of it. We're talking about social determinants, talking about housing. It's very difficult to monetize the investment in housing in the medical cost of care. And as a result, you don't see this really happening very much in many health systems that are living in the cost of care, the insurer's view of the world. The other way of thinking about this is, what's the cost of no care? Right? What happens for Dr. Mercer's patients if we don't do anything? Well, we've already said someone's going to die early, and I would argue that matters. It matters because it's the right thing to do, to offer love, compassion, dignity. It also matters because, health economists are very clear. Life has value. A low-end number of that is maybe $50,000 per year of life. I'll just put that number out there. It also matters because some of the folks that we care for get back to work. Right? And it's not just folks who are experiencing homelessness, folks who have a sudden heart condition, and we take care of the heart condition, they get back to work. And maybe if we prevent a devastating stroke for any one of us, for example, there are likely other people who depend on us. It's not just us, right? There's a big economic productivity component to this. And then there's the medical cost of failing to prevent that stroke, failing to prevent that kidney failure or that end-stage cancer. And we've actually measured this cost of doing nothing. We've measured it in Texas. So the St. David's Foundation, the Episcopal Health Foundation, and others funded a study called The Economic Impact of Health Disparities in Texas. Each individual, we failed to prevent that stroke. We failed to prevent that cancer. What was the total cost of the medical expense, the lost economic productivity, and the lost life and the value of that life? Any guesses what that is in Travis County today? It's $1.1 billion every year. That is the cost of doing nothing, and I would say that's the low-end estimate of the cost, because if you or I get taken out by a devastating stroke, it's not just the individual, it's our families, communities. It's at least $1.1 billion. That's the cost of doing nothing.
Wow.
When you take that into account and then ask, well, how do you pay for the giving somebody a sandwich and some socks and taking care of them today and getting them MAP insurance? That might be pennies on the dollar against what you would lose if you don't. Not the medical cost of care, but the entire public's cost of allowing people to not get the care they need, to not get the food, transportation, education, housing, love, compassion, dignity they need. And the total cost to our community is massive. If we had to pass that bill to spend $1.1 billion to let our people die 10 to 20 years early, mostly Black and folks of color on the streets, in the jails, in Travis County, we would never pass that bill. But that is what's happening today, and that is the work that we're trying to do. So at a policy level, could we think about ways that we create combined health and social authorities that are looking at the entire cost of doing nothing, not just the medical dollar, that are accountable to that, accountable to the public, accountable to taxpayers, and therefore able to braid all the funding sources, the third-party payers, insurers, Medicaid, Medicare, the tax levy dollars, other federal grants and dollars, braid that together into a pool of resources that would allow us to get a really good return on investment for the public by preventing things like that $1.1 billion. See the whole size of the cloth and see where it breaks if we only look at this piece when in fact the problem is this big.
Sure, yeah. Makes a lot of sense. Are there any efforts, any sort of primitive or, discussions that have been had about some of what you're sharing about, or is it just a concept? Is that being discussed? Anybody having?
Yeah, well, I think we're doing that right here in Travis County.
Sure.
Right?
Okay.
That is
good.
what we understand is our opportunity. Central Health, Community Care, Sendero. taxpayer created, accountable to the public, accountable to patients, and really understanding that our job is not to return value to shareholders on a quarterly basis. Our job is to return value to the public on a generational basis, to improve health of our community, to reduce or eliminate that life expectancy gap east and west of I-35 with all of our partners, knowing that we got to work with the entire society to do this, but that we can serve as a trunk for health, one trunk with many branches connected in with the patients at the center, love, compassion, dignity at the center, and return value to the public, over the long term. That's what we're trying to do here. I think we're well on our way. We got a good start. And if we are successful, then our example here, I think, could be relevant to other urban communities with at least a stable or growing city. If a city is in decline, that's harder. But if the city is stable or growing, I'm not sure I see anything about what we've done here that couldn't be applicable and tailored to that local environment.
That sounds like a great idea. Great idea. And I'm glad that the commissioners you've engaged them and they can see some of the efforts, and hopefully there'll still be an ongoing conversation. I look forward to being a part of that when those happen. So
we look forward to working with you. We can't do it alone. So, we have to work with our partners, housing partners, other partners addressing pieces of all these social determinants. It has to be done together.
Yes. I'm a big believer in that. So thank you for that. So, gentlemen, I really appreciate your time today. I mean, this has been really enlightening and inspiring nonetheless. So I'm so happy to have had this opportunity. So any parting words? I mean, you've shared a lot, and we have, hopefully the audience will have a lot to think about and think about how they can contribute to seeing that some of these needs being met, and think about in their own individual situations how they can contribute and add value. So any parting thoughts?
Well, no, thanks for the opportunity to have this conversation and really just continue to spread the word or the gospel of how all these determinants of health are related, and how that speaks to the need that we have to come together. And it's a real privilege to work within Central Health as a steward of public tax dollars to help our community ensure their right to health. So look forward to the work to come.
I'll offer one thought, Patrick. I think the audience is well aware. These are uncertain and difficult times for the work that we are doing, the work that we're all doing together. But I'm reminded of a core lesson that I once learned from one of my mentors, who said, optimism is a moral choice. It's not necessarily the choice that makes the most sense or the easiest, but it's what you do when the alternative is simply not acceptable. And I would argue that the body of work we've been talking about today, the alternative is not acceptable. So this is a moral choice. We choose optimism. But this mentor also said, good intentions are not enough. If you try to make that change and you fail, you've used up very important resources. It could be financial resources, political resources, the energy for change. And so you have to learn how to be effective. And so what we are aiming to do is to not turn our efforts and gaze away from the core issues of access, of dignity, of comprehensive, compassionate care, and also, just as rigorous, how to be effective through partnerships, through real trust and relationships, by hardwiring excellence and improvement throughout our system, by sweating every public dollar and making sure that we are making the absolute best use of the resources at hand, and we're going to do that as well. And so I just, grateful to be here with you, grateful to be here in our community, and thank you for having us, Patrick. It's really an honor.
Thank you. Love, compassion, dignity.
Yes, sir.
We're going to end on that note. I'm Patrick Howard. Thank you for joining us. Look forward to having more conversations. Have a great day.